Right. Thank you very much, everybody, for joining this workshop. I'm sure you will find it useful. What we are going to do is that I will have this an interactive session about the OSCE. Then we will divide the participants into four groups, and each group would prepare a question and a station with the marking scheme and the scenario, and then each group would present and we would discuss. So this would be a kind of hands-on session. So what I'm aiming is that by the end of this session, you would have prepared at least one OSCE station which you can use in your institution. Right? Is that okay with everybody?
Yes, sir.
Right. Now, we actually, this is going to be a conversation. So let's not make it a one-sided conversation. So each one of us will share their experience, their opinion. And if you have any question or comment, you can stop me anytime and we will clear it. So don't make it sort of formal lecture, but it's more of conversation. Right, let me switch on my temperature here in Malaysia. The part I am is 39, so it's in a way quite comfortable for us who are familiar to live in this situation. Now let me start with the point to emphasize that OSCE is an assessment tool which has been accepted or which has been recommended and adopted internationally. So we should not underestimate the importance and the relevance of OSCE in our assessment. Sometimes, and in fact, in myself at one time used to feel that this is one way of simply helping the students to pass the exam, but actually it's not, right? And we will see the first thing is that OSCE is a performance-based assessment tool, and it is being used in the high-stake exams like exit examination during the undergraduate years in most of the medical schools around the globe, including United States, United Kingdom, and Canada. So this is an accepted tool for assessment of high-stake examinations in both the developed and developing countries, especially for undergraduate students. And it's not just for undergraduate students, but even for postgraduate students, the high-stake assessments. For example, the Royal College of Physicians, they what they call is PACES, the practical assessment of clinical examination skills, which is again a form of OSCE or variant of OSCE. So it is being used both for undergraduate and postgraduate assessment. And not only for undergraduate and postgraduate assessment, but also for license and certification. For license to practice, the OSCE is used as one of the tools to issue or to decide to issue the certificate of for practice. For example, in CLAB and in Medical Council of Canada qualifying examination, and the USMLE and FCPS in Pakistan. So all these institutions are using OSCE not only for assessment of undergraduate and postgraduate students, but also for assessing the practitioners to allow them to practice. Apart from that assessment, it's also being used for formative assessment to give the feedback. And in fact, it's a very useful tool to conduct the formative assessment and provide the feedback to the students there and then. And obviously, this is one opportunity where students can be given feedback immediately after they have performed on the station. Now, what we are going to do today, the first part, which is the presentation. So I will address these questions. What is OSCE or OSPE? Why it's needed? What is so good about it? What are its limitations? And what is the role of OSCE or OSPE in assessment of medical students? And this would be the first part. And the second part, as I mentioned earlier, all the participants would work in groups and they would construct questions and set the stations, and then we would discuss about it. The learning outcomes that we wish to achieve from this workshop. First is that the participants will be able to explain the rationale for preferential use of OSCE. I think that's important. We should know the reason, the real background. Why is it that we want to use OSCE? And then the second is construct valid and reliable questions. So with the practice, with the hands-on session, inshallah, we'll be able to construct valid and reliable OSCE stations. And then the organizing the OSCE stations following the prescribed rules. And finally, identifying the limitations and challenges in the development and conduct of OSCE stations. And purpose of this is that by identifying the limitations, we can try to improve on those areas and to reduce those limitations. Purpose is not to criticize, just to criticize OSCE, but purpose is to improve OSCE by identifying its limitations. Right, let's go to the first part, which is introduction to OSCE. And so OSCE is already almost 50 years old, so it's not something new. And it was initially introduced by Harden and Gleason in actually originally 1975, but from 1979 it was being used in many institutions. And the concept of standardized patients was actually introduced in 1993, because now we know that the standardized patients, they make a very important component of OSCE. So it was in 1993 that the American Medical Colleges, their association, came up with the concept of using standardized patients in OSCE stations. Now, let's look at this statement. It's important to understand OSCE. It was designed as a novel evaluation tool, allowing the assessment of candidates' clinical skills, number one, attitude, number two, problem-solving abilities, number three, and ability to apply the knowledge in one examination. Means that one OSCE can assess at least 4 areas: clinical skills, attitudes, problem-solving abilities, and application of knowledge. But if we look at it carefully, actually that's what we were doing in our long case examination. In our traditional long case examination, we assess clinical skills, we assess attitude, we assess problem solving, and we assess the application of knowledge. So exactly what we were doing in traditional long case, the same thing was being achieved by using OSCE. And that is where the OSCE was introduced to replace the long case. And the reasons were counted at that time. And now when we look back, some of the reasons may not be valid at this stage, but we will go into the detail of this point of replacing the long case examination with OSCE, where both are testing the same attributes. So let's keep this in mind for our discussion. And using the same principle, the number of other variants, especially the OSPE, has been coined, where it is the objective structured practical examination, mainly for preclinical areas. So OSCE, objective structured clinical examination, mainly for clinical areas, and OSPE mainly for preclinical areas. But of course, both would have some overlap as well. The OSCE is an assessment tool based on the principles of objectivity and standardization. That is the main emphasis, or you can say the main selling point of OSCE is its objectivity and its standardization. And this allows the assessment of candidates' performance against standardized scoring schemes. So objectivity is predominantly depends upon the standardized scoring rubrics, the same trained examiner, and same questions, right? So to the objectivity, because so means the reducing the bias is mainly these. There are three main tools which OSCE use. There is a standardized scoring rubrics. We know for each OSCE station, there would be a marking scheme, standardized marking scheme. And every student on that station would be examined by the same examiner. So means it's the standard scoring, it's the same examiner and the same questions. So this means that every student is going through exactly the same exercise. So there is no variation like we see in, for example, traditional long case, where every student gets a different case. So here objectivity is the same scoring scheme, same examiner, and same questions. And this, of course, definitely would improve the reliability. The next point we should understand about OSCE is that this is in a simulated environment. This is not in real environment because it is conducted in, for example, either clinical skill labs or other areas, and it is not conducted in real environment, which is in the hospital. And it is at the show level. If we see at the Miller's pyramid, the OSCE comes at number 3, the shows, because the student or the candidate shows us how they are performing. Whereas if we do it in the hospital, like traditional long case or short case, that becomes at the does level. So OSCE is at the show level of Miller's pyramid. Right, now this is a descriptive definition. And this would help us to understand how the OSCE is conducted. Of course, it is a performance-based assessment tool based on objectivity and standardization, which we have just discussed, how the objectivity is achieved and how the standardization is maintained. And in this, the candidate moved through series of time restricted stations in a circuit for the purpose of assessment of professional performance in a simulated environment. So students rotate through different stations, and at each station, their professional performance is assessed. And of course, it is a simulated environment, not real environment. And at each station, candidates are assessed and marked against standardized scoring rubrics by trained assessors. So this appears a bit a complicated statement, but it describes how the OSCE is really conducted. And if we break down this definition into small components, that would help us to understand. First, it is a performance-based assessment. Second, it follows the principles of objectivity and standardization. Third, the candidates move in a circuit from one station to another. Fourth, each station is time restricted. In fact, each station is of same duration, and it is in simulated environment. Assessment and marking is done against a standardized scoring scheme, and assessors are trained. The examiners are trained. So I hope by this descriptive definition, we can understand how the whole process of OSCE is conducted. This is how it appears that there would be number of stations, and students would move from one station to another after the fixed time. So every station has the same time and duration, and students would move from one station to another. And at each station, student would be examined by the same examiner on the same questions using the same standardized scheme to assess the students. Right. Now, here are some examples, and these examples are from basic sciences to begin with, both for observed and unobserved stations. I'll explain in a short while what is observed station and what is unobserved station. Now, for example, in anatomy, we can use the specimens of muscles, bone, nerves, arteries, veins, or we can have the surface anatomy, whether on mannequins or whether on the standardized patients. For example, using surface anatomy to assess the clinical application. For example, asking students to identify the sternal angle, or count the intercostal spaces, or identify the auscultatory areas. These are few examples. For example, a scenario that a patient presents with Erb's palsy and identify the damaged nerve in the specimen. So a specimen or a model is there, let's say of brachial plexus, and the scenario is that a patient has presented with Erb's palsy, and student has to identify the nerve of which is damaged. This means that student must understand what is Erb's palsy. They must understand which is the nerve involved in Erb's palsy, and they should be able to identify the nerve in the provided specimen. So that becomes one OSPE in anatomy. Or another example, that movement of arm above the shoulder is restricted. So there is a patient who has this problem, and the student is required to identify the involved muscle in the specimen. This means, again, student has to know that which is the muscle which is involved in this patient's complaint, and they have to identify that muscle in the specimen provided. So you can see that it is really an application of knowledge, an application of knowledge in clinical skills, which makes sense, the purpose for assessing and training of students. Similarly, we can use radioanatomy, radiographs, CT scan, MRI, and we can also have scenarios and specimens based on surgical or applied anatomy. So these are few examples for anatomy. Similarly, we can use the slides, histology and in pathology, but each station must have a scenario. And in microbiology, again, slides of microorganisms. In parasitology, organisms are ova. In physiology, we can ask students to, for example, measure blood pressure, pulse, heart sounds, cranial lows, or ECG, etc., depending upon what level we are assessing. In biochemistry, we can, for example, ask them to examine the urine specimen or blood sugar, etc. In hematology, similarly, we can put the slides of, let's say, iron deficiency, anemia, thalassemia, or others to assess the student. But important point is that each specimen must be accompanied by a scenario. Here is another example from anatomy. The slide of urinary system, which is provided. And the first question is identify the organ. And second is state any 3 features seen in the slide that help you in identification of this organ. Now, important point here is that first is identify the organ. Okay, student might identify the organ or somebody might whisper in the ear. But the second is very important, that you have to give features which are seen on that particular slide. It's not that student can answer based on the theoretical knowledge, but they have to note the features which are seen on that slide. So again, it's becomes really searching and something which students have to really look for. Now, having said that, now again, let's come back to understand the concept of OSCE. And here is a statement, a very useful statement, that OSCE is not a test method in the same way as essay or MCQs. It is basically an organizational framework consisting of multiple stations around which students rotate and at which students perform and are assessed on specific tasks. Now, these OSCE stations are actually a platform, and we can use that platform for a number of different purposes. So there are a number of things which can be assessed on these platforms. There can be clinical skills, there can be procedures, there can be counseling stations. So this means that OSCE is a platform, and we can use that platform to test a number of different areas, and that is one strength, that we can assess so many different areas by using OSCE. So let's take it not as a test method, but as a platform where different areas can be assessed. Now, that is so far about the concept of OSCE. Is there any question? Anybody want to raise any queries before we move on to the next part, which would be the rationale of using OSCE? There any questions?
Yes, I've got the question.
Yes, please.
My name is Imtiaz, and
Yes, Mr.
I
Imtiaz. Yes.
would like to ask a question regarding the number of examiners in the OSCE. Is
Right.
it one examiner suitable or 2 examiners to remove the examiner bias?
All right.
Thank you.
Okay. I will be actually addressing this part in the second part of presentation. But your point is well taken, and we will be discussing this. the whether the pros and cons of using one examiner or the other. Of course, if we are using two examiners, then this means that we need to have more staff involved. But whether we can, by using the standardized marking scheme, can we achieve the same objective rather by using only one examiner? So we will be, this would be a part we will be discussing in our second component, inshallah. Right? Yes, Dr. Anshu. Yeah. Dr. Kabir. Yes, Dr. Kabir first. Yes, Prof. Kabir.
Yeah,
Yes.
Prof, thank you. You said that the OSCE, this is real environmental based, not the simulation. But sometimes it could be simulation also, right? That's
No,
my confusion.
that's what I'm saying, that it is a simulated environment. This is not the real environment.
Understand. I may.
Yeah, because for example, the long case and short case, we are dealing with the real people with the real life situations. Here, it is not the real life situation.
But if we have this patient bank that I had experienced in my life, but if we engage those patients, real patient in the OSCE station in the active part, it could be real environment sort of, right?
Yeah, but that would be possible if you have very small number of students. If you if you have, let's say, 100 120 students, so of course we won't be able to use the real patients, right? So that's the limitations. Okay.
Thank you.
Dr. Anshu, please.
Good morning, sir.
Good
The
morning.
question I wanted to ask is that, especially in the preclinical and the paraclinical subjects, just like the anatomy and the pathology stations that you showed, people usually have something like spotting. They keep a slide or a specimen and say identify. So, and it's always a struggle to explain to faculty that this is not OSCE. So, how? What are the messages we give them, especially if in a subject like pharmacology? What kind of OSCE stations can be produced there?
Right. I think you, Dr. Anshu, brought a very interesting point. Actually, especially the graduates of my age, they would know that we used to have this spotting, especially the histology slides, and there used to be 10 or 15 slides, and we would move from one slide to another on the ring of a bell, and then we would identify the slide. And that was, you can say, a primitive form of OSCE. And I also remember that we used to identify the slides because we had some clues that that slide which is broken on the corner is this one, and slide which has this color. So that used to be this. But basically, if you look at the name, the objective, structured, practical examination, are objective, structured, clinical examination. It has to be objective, it has to be structured, and it has to be practical or clinical, and it has to be applied. So just going through the slides does not serve the purpose at all, right? So that defeats the whole purpose. As I mentioned, let's say I was giving the examples of anatomy, for example. You can straight away identify that nerve. But here you are going much above that level. You are giving a scenario where students have to know the nerve itself, has to know about that condition and identify. So this is, I'm sure you can realize that this is much more at higher level and more searching as compared to our traditional spotting which we used to have. So I think that should be the principle whenever we want to have OSCE and OSPE. Number two, we must realize that not everything can be assessed in OSPE or OSCE. There would be certain very important areas which cannot be assessed by our OSCE or OSPE, and we have to find other ways of assessing that. Now, you are talking about pharmacology, and the people have these high level mannequins, high fidelity mannequins, where they can demonstrate the effects of drugs, for example, on heart rate, respiration, or other biochemical areas. So, are like no, you another we used to do was the asking them to, there's a simulated patient and he presents with certain condition, and student has to make a diagnosis and then write a prescription for that particular patient. So that's basically the concept is not just recall, but actually relating it to real life situations and assessing those skills. That's the real spirit behind this approach. Right? Any other questions before we move on to next? Okay. Now, why? Just to understand the rationale of using OSCE. So, first question is why OSCE came to light at the first place. So look at this. Now, a candidate assessment can be affected by four factors, right? A clinical assessment. First, the patient's performance. Now, how cooperative the patient is with the student. That's one factor. Second, the examiner behavior, examiner bias. Third, the marking scheme. And fourth, the candidate's actual performance. Now, these are four factors which are affecting a student's performance. Ideally, it should be only the candidate's actual performance. But if I'm talking about, let's say, a long case or a short case, where the patient's behavior or patient cooperation, maybe patient is okay with first few students, then get tired, and then he or she is not cooperating anymore. And because there is not a standardized marking scheme, so examiner's bias would come in. And I mean, the most important thing is students' performance, but that would be affected by so many other areas. And this is what OSCE does. OSCE reduces the number of variables because now there is a standardized patient, there's the same examiner, and there is the standardized marking scheme. I'm not saying that OSCE would eliminate these factors, but it would definitely reduce this. And that would mean that to a great extent, a well-designed OSCE, the grades of candidates would be based on the performance of the students because OSCE is trying to control the other three confounding factors. So that is one rationale, a strong point or a selling point for OSCE, that that it reduces the confounding factors and the tries to assess the students based on their performance and not on the other factors. So that is one point. The second here is it's here looking at the traditional long case and the short case. Now, long case or even the short case, we know that there is inherent intercase variability. every student might get a different case, and so-called some students get easy case and some students get a difficult case, so they do not go through the same exercise. This is one view. The counter view is that it is the realistic. Now, in real life situation, every student would not, or every graduate would not get the similar patient. So we can argue on both sides, but in a way to be fair in our assessment, students are given the same kind of situation. The second point, a single case does not allow the assessment of candidate performance on a range of areas, restricting the sampling of test universe. We know that we cannot have many long cases because of for the logistic reason. So we cannot say that by just if a student has done well on one case, they would be doing good in other cases as well. Kindly mute yourself, right? And the next point is that we cannot generalize. If, for example, student has done well on examination of respiratory system, we cannot generalize that because student is good in assessing the respiratory system, they would be good in assessing other systems, for example, central nervous system as well. So these are the limitations. So again, I say first is the intercase variability. Every student gets a different case. Second, the sample size is too small. Just having one long case or few long cases doesn't really make it such a reliable assessment. And third is that we cannot generalize, means student doing well in examination of one system does not necessarily mean that they can assess all systems. But there is a possible solution. And that is that, for example, in year 5, we have 4 or 5 rotations. And if we have a long case examination at the end of each rotation, and we make that long case assessment as a part of continuous assessment, then we can say that we are not deciding on just one case, but we are deciding on, let's say, 6 or 7 cases and long cases, and that can make it more objective and reliable. That is the other side of it. Basically, what I'm trying to do here is looking at both sides, the OSCE side and the traditional side, and comparing where which one is better or which one is more feasible. And if we are adopting OSCE because there are inherent problems with the long case, so how can we address those problems and try to improve the long case examination if we do not want to adopt the OSCE. Now, the next is, for example, the Viva Voce examination. And these examinations allow the assessment of recall of knowledge, depth of knowledge, hypothetical problem solving, judgment, clinical reasoning, analytic skills. So many things we can assess in Viva examination, and this is good because there is a physical presence of examiner and the student, and you can discuss and clarify the point there and then. But the problem would be that if it is unstructured, if we are having different scenarios and different questions for different students, then it becomes less objective and less reliable. This means that if we use a structured Viva, that would be much more closer to the OSCE or OSPE as compared to unstructured. And the other way is that if you are familiar with multi-part MEQ, those MEQs can be used as structured viva. So again, the problem of with the traditional viva can be handled by structuring it properly. Right. So that was discussing actually the rationale, why there is a need for OSCE and how OSCE can address the problems which we face in traditional long case, short case, and our viva examination. Now, as I said earlier, that OSCE is a platform, and that has resulted in a number of variants of OSCE. And the reason I'm putting it here is that sometimes it becomes very confusing when we are reading in literature of these variants. One is OSPE, which I have already mentioned, is an objective structured practical examination. Of course, it follows the same principles as original OSCE, but this is one variant used for assessment of practical skills and mainly for in preclinical areas. Another is OSTES, the objective structured assessment of technical skills. And this is basically used for surgical specialties, where the designed or objective skills assessment consisting of global rating, but mainly based on the procedures and surgical skills. OSWE is an objective structured video examination, where the videotaped recordings of patient doctors encounters are shown to the students, and they are asked to identify the problems in are the good points in those videos. Similarly, there is TOSCI, Team Objective Structured Clinical Examination, and there are a few more. The TOCS, Task Oriented Assessment of Clinical Skills. This is being used by College of Physicians and Surgeons in Pakistan. TOSCI is a task integrated objective structured clinical examination. And then there is OSWE. Previously, OSWE, we were talking about the videos, and here it is objective structured viva voce examination. And then there are integrated OSCEs, which can be based on the one discipline or multiple disciplines. So you see that we have so many different variants of OSCE. All of them use the same principles, which was the original OSCE, but different institutions have modified them. But unfortunately, most of these variants, they have not been really validated. And it is assumed because the OSCE would work, so these variants would also work. And so the reason I brought in this here is that when you go through the literature, you might find these different variants, and you might be wondering what it is actually happening. Right, now, having said all the positive things about the OSCE, let's look at the limitations. Obviously, no single test method is perfect, and there are a number of limitations, and OSCE is not any exception. First thing, as I mentioned, it is at the show level. It is not at the DUS level. So when we do it in the real life, we really see the skills in real life situations, which are very relevant, whereas the show may not really reflect whether a student would be able to do the same thing in real life or at the DUS level. So that is one limitation. Second, it is a simulated environment. It's not a real environment. and simulated environment itself can influence the performance of candidate. Therefore, the performance of candidate in OSCE might not be the same as their performance in workplace. For example, it's expected the student would come, there is a mannequin and student would come and greet and then smile and introduce, which of course nobody would do in real life. So that becomes a totally a different situation and unrealistic. So that is a second drawback. Third is that OSCE in our real life, during our examination, apart from clinical skills, we assess a number of other skills, which you can call non-clinical skills, like team working or resource management or situational awareness. Imagine examining an infant, a real infant, in the ward compared to an infant mannequin in the clinical skill lab. So you can see the difference. Handling a real infant in the hospital would need a lot of non-clinical skills, whereas a mannequin would not have that kind of situation. So that clearly shows that how the limitation of OSCE in a simulated environment, which is far away from the real environment, right? So that this is another limitation of OSCE. Then is the compartmentalization, because here sometimes we assess the procedures in isolation without any context. For example, asking the student to do a pap smear on a model. Now, which would be, of course, very different than the real life. In a real life, you would have to talk to the patient to explain the procedure, to answer the questions of the patient. And here it's just doing on a model can become very mechanical. Although now people have addressed that issue that along with the mannequin, there is a real person and student would, a simulated patient and student would talk to the simulated patient, but would perform the procedure on the mannequin. But that is again one limitation of OSCE. And many a times, I'm sure you have seen yourself that instead of assessing the clinical or practical skills, many OSCE stations, they are based on the theoretical knowledge, which defeats the whole purpose, because it is supposed to be a clinical examination, not a theoretical examination. Here is an example. For example, in one station there is a lab report, and students examiner may or may not be there, and student is required to interpret that lab report. So actually that's not the real OSCE, because this can be done very easily in other ways of examination, especially in the written examination. So that would not be a right approach to assess this kind of knowledge, which can be assessed through written examinations. So here is a statement, a very important statement. We read it. Poorly structured OSCE stations may lead to candidates learning skills to pass examinations rather than to improve their actual clinical performance. So means that if we are not careful, structuring our OSCE stations, we might be compromising on our assessment and teaching situations. Right. Another one, OSCE is less feasible because it is expensive and labor intensive. Validity of OSCE is also compromised at the cost of achieving reliability. Fragmented presentation of the context in a number of stations make it less authentic because it is not an holistic or integrated assessment. Again, now we see because there are the student number is more, so we run these OSCE in multiple circles. So this means that the original concept that each student would be examined by the same examiner would not be there. Each circle would have their separate examiners. So in that way, the objectivity is being compromised to some extent. Now, here is the summary of these limitations. Number one, it is an unrealistic simulated environment. It is a show-how level. It cannot assess non-clinical skills. It is fragmented, compartmentalization, not as objective as perceived, not as standardized as perceived because of multiple circles. It is testing the skills and not competence. When we say assessment of competence, that means application of knowledge, skills, and attitude, whereas most of the OSCE stations would be doing only on the skills. Validity compromised at the cost of reliability. Now, we use these checklists, and sometimes they are very minute checklists, and examiner is busy in just looking at the checklist rather than looking at the candidate's performance. We need to train the simulated patients. We need to train the examiners. And if we are using high fidelity mannequins, they are very expensive and difficult to maintain. And there is a labor and resource intensive. And finally, some of the stations end up attesting theoretical knowledge. Now, I'm emphasizing on these limitations and describing them in detail. Purpose is not to discourage you from using OSCE, but purpose is that we should realize the limitations of this approach, and we should address these limitations. Unless we know the limitations, we cannot address, and the whole purpose is by addressing these limitations, we can improve the standard of our OSCEs. All right, so having gone through that, here is some examples of addressing these limitations. One is that we can have a combination of mannequins and standardized patients. Right, for example, when we were talking about the pap smear, so there is a female standardized patient, and the student explains the procedures and answers the questions of standardized patient, but performs the procedure on the mannequin. So in this way, we can address some of the limitations. For example, now we are not doing only the skill, but we are looking at the competence and bringing it as close to reality as possible. The second is, let's say, the mannequin standardized patients plus RDOs. Now, here I give you an example. We used an OSCE for third-year students, and we used mannequin and asked them to, let's say, identify the sternal angle and identify the auscultatory areas and how to look for apex beat. And after that, we used an audio, and it was a murmur. So we played this audio and said that this murmur is heard at the second intercostal space on the left side of the sternum. And then what is this murmur, and what would be the possible diagnosis? So in this way, either using mannequins or standardized patients, and using the audios along with that, these audios can be cardiac murmurs or heart sounds, or it can be respiratory sounds. So again, we can bring it closer to real life situation. Third is the mannequin and input by examiner. The students perform examination on mannequin, and we look at the technique of the student. But then for the different examinations, the examiner provides the input. For example, there we said that we heard a murmur. So the student is, the technique is seen on the mannequin, and some findings are given by the examiner, and then student is asked to interpret, and relevant questions are asked. So if the number of students is large, and rather than running the multiple circles, we can divide the stations based on the disciplines. For example, on day 1, students can do the OSCEs related to medicine or medicine plus surgery, and on day 2, they can do the other. So in this way, we can reduce the number of stations on that particular day, limiting to 1 or 2 disciplines, and then we can conduct it on 2 or 3 days, rather than doing the multiple circles, because multiple circles can compromise number of different factors. So this is actually by pointing out the limitations and then providing the solutions to some of these limitations, we can improve our standard of OSCE. And that was the whole purpose of bringing this, that let's identify the limitations, the challenges, and then find the solutions to those challenges by combining different resources. We can actually address some of those limitations quite effectively. So having said that, an ideal summative assessment program needs to be based on combination of assessment tools in a test battery approach. Means that we should realize that OSCE cannot test everything. So we have to have multiple assessment methods, or what is called the menu or test battery approach, where OSCE is one of the assessment method and not the only assessment tool. Right? And it is not possible to test all levels of difficulty within each domain with the use of OSCE. So OSCE, along with other assessment tools, would make a good assessment as compared to OSCE alone. So OSCE is best used for, number 1, communication skills, like counseling skills, health education, or obtaining a consent for a procedure. Can be best used for procedures which we cannot do on real patient, like intubation or CPR or intravenous line, or demonstration of different devices, like use of inhalers. And for clinical examination, where we can combine the mannequins with the simulated patients. I given the example of pap smear, rectal smear, or ENT, or ophthalmology examination. So these are the situations where OSCE can be most useful. Now, can we stop here and see if you have any questions before we go to how to conduct the OSCE. Any questions or comments? Please feel free to express or share your experience.
I've got one small question, Professor,
Yes, please. Yes.
regarding the number of OSCE station. As it is labor intensive and it takes time, and usually
You
try to
see,
run it over one day.
Dr. Imtiaz,
Yes.
it's actually interesting that you are asking the question which I'm going to address.
Okay, later on.
Uh,
Thank you.
Basically, I think you can anticipate what I'm going to say in a few slides later. I'm going to discuss that definitely. Both of your questions, inshallah, we will be discussing. Right. Yes, Dr. Anshu, please.
So the problem with the checklist that people produce, one is that the students memorize them and come, and even if you try very hard after the second cycle of using the same checklist, usually the checklist is leaked. So, so what is the solution for that? And the second thing is, as you already said, if the checklist is too minute, the examiner is looking at the checklist rather than the student. So, and how much of training do we require, and when do you advise global checklists, and when do you advise too much of stratification in the checklist, which causes problems?
Right. I think that's a very, very important question here. Okay, if the checklist is too minute, like you said, so one is that it would not be student friendly. Second, examiner would be actually too busy to fill that checklist. And thirdly, we are not using the expertise of examiner at all. The examiner is there just to fill the checklist, and his expertise not being used at all. So first thing is that when we make the checklist, it should not be really too minute. Mainly should cover the broad areas, and we should give some space to the examiner so that they look at the student and they see how they are performing. So we should try not to make it really too detailed and too minute. That's number one. Number two, you said that the students can memorize. I don't know what situation you are talking about, because because we are running only once. Is that station would be run only on that day, and students are in quarantine, so they would not be actually able to get what is there in the checklist, even if somebody has memorized. Although it would be very difficult for students who is so nervous in the examination and has only 5 minutes, they would hardly be able to memorize it. Now, thirdly, leaking the checklist, of course, is a problem with the institution, and that should be looked into. But here, the point here is that the checklist should not be too minute. It should be on major principles, not on the minor prints, and it should not really be so detailed that examiner is all the time worried about the checklist and not about the student at all.
So
Okay.
my question actually was that
Yeah.
usually when we before introducing it for the exam, we
Right.
have a few trials where we do the OSCE. So the same question might turn up there. So students get used to it. They know that there are marks for greeting a patient or something. So those things and all they know. So they know if that scene number we get three marks or 4 marks on those questions.
Right.
So it's unfair for them also if we don't introduce OSCE in the class and then give it in the examination. So
Now,
how do we do this part?
I think it's very fair to have some mock OSCEs and train the students how they are going to appear in the exam. If we do not do that and students are not familiar with that, it would not be fair at all with the students. So they must know how the OSCE is being conducted and how they would be marked. Now, it is good if, for example, students know that they have to greet the patient. And if they are greeting, if you are, let's say, mock OSCE are training the students on the right skills, that is plus point. If students are doing what we want them to do, so that's fine. That's fine, isn't it? But again, is that in mock situations or in training the students, we give them examples. We do that on different and try not to use exactly the same questions in the examination. Now, for example, we teach the students that they should greet the patient. And if they are coming and greeting the patient, that's good, isn't it? So the student should get credit for that. But I fully agree that students should know how the examination is going to be conducted and how they would be marked. So students know that if they greet the patient, they would be given marks. So, and that's fair enough. This is what we teach them, that you should greet the patient, right? So let's be a bit more open about it. That if students are doing the right thing based on our training or even mock stations, so they have learned from the mock station, right? Okay, the next is somebody is listed iPhone. Please unmute yourself. The name is not there, it says iPhone only. You have raised your hand, please. Okay, nobody is responding on that. Somebody listed as iPhone and not the name has raised hand. Okay, so that is about the uh, you know, basic principles, basic knowledge, understanding of OSCE, the usefulness of OSCE, the rationale why it should be used, and then what are its limitations and how we can address these some of these limitations. So our next is the how the OSCE is conducted, and I think here Dr. Imtiaz has asked a couple of questions which would be addressed in this part. Now, how the OSCE is conducted, I'm sure many of you or all of you are familiar with the way it's conducted, but we will go through that and we might find that there are some areas which we need to improve. So first thing, OSCE is primarily a competency-based assessment performance in simulated environment, and therefore principally assess the skill-based learning outcomes, right? So OSCE should always be based on the skills, clinical methods. So blueprinting is the requirement for that. The blueprinting means that appropriate spread of sampled capabilities which we are going to assess. It means we have to plan what are the capabilities we are going to assess in the OSCE. I'll give you the examples. If we do the blueprinting right, it leads to constructive alignment. It improves the validity and authenticity, and it avoids unnecessary duplication. If we are not careful, we might be asking the same questions again and again. For example, nephrotic syndrome in the written examination as long case, as short case, as well as in OSCE. So if we have blueprinting, that can avoid this duplication, or we can be asking the same system questions in so many different examinations or different components of examination. So blueprinting is done twice, before the construction of OSCE and after the construction of OSCE during the vetting session. I'll give you the few examples here. Here is one way of looking at the blueprinting. If we are still using the long case, so basically what we need to do is that we make a list of all the conditions which we wish to examine. In a way, make a wish list that these are all important areas which we need to assess during this, let's say, final year examination. And from that list, we cross the conditions which are likely to be assessed in long case. For example, we have number of conditions listed there, and we would know that which are the common long cases which are assessed in the examination, usually chronic cases with clear history, well investigated. They may not have very clear physical findings, but that would make the long case. So from your list which you have prepared, you can strike out the conditions which would be assessed in the long case. So then you see what would be the short cases. Basically, these would be the cases with physical signs and focused examination. So that would be the second list which you would cross from your wish list. Third would be the OSCEs. Let's say about the procedures, communication skills, videos, audios, growth charts. And so you strike out those conditions. Then would be the questions in essay questions, where we would be assessing pathophysiology, emergency situation, data interpretation, and then the remaining would be in multiple choice questions. So this is a gross method of sequencing, that if we are using these assessment methods, so in this way we can spread out the different conditions and avoid the unnecessary and duplication. I'm not saying that something which has been assessed in the long case would not be assessed in the theory at all, but at least it would be the different aspects. It would not be, if we are assessing the, let's say, in our long case, we are assessing epilepsy, and then in the same long case, we are assessing how to manage epilepsy, then we should not be asking this management of epilepsy in our written examination. So in this way, we can spread out the areas, and we can avoid duplication. And basically, our examination would test a wide range of areas. The other is the blueprint for OSCE. Now, here we have the different systems, CVS, respiratory, or gastrointestinal, or you can have specialties here. And then we have history, and we have the explanation or communication to the patient, or we have the physical examination, we have procedures. So in this way, using this kind of chart, we can spread out different areas in this. So that would also help to avoid the unnecessary duplication, would help to cover most of the areas, and at least all the major conditions, major situations can be planned and assessed appropriately. So blueprinting is very, very useful before actually conducting the OSCE. Then is once we have done that, and now we know that what kind of stations we are going to have in the OSCE, then we have to plan and prepare for those stations. And this is quite a meticulous work. Administration means we have to identify the venue, the resources, whether we are going to use some specimens, we have to move those specimens or move the equipment. Then the laying down the plan, then the construction of stations, the directions and the signages for movement of students from one station to another. Then running the OSCE itself means timekeeping. For example, if every station is 5 minutes, so there has to be a bell, a ringing bell after every 5 minutes so that students can rotate. We have to see that students rotate in the right direction. And in between, we might have to change the standardized patients because the same person may not be able to sit the whole day. And then we have to have breaks in between as well. So to give rest to the examiners and as well as to the patients. And if we are using multiple sites, then there would be issues with that, multiple cycles or repetition of cycles. So it means that it really needs quite elaborate and meticulous plan. Then we have to train the standardized patients. This is very important area. And sometimes the patients, they do not really understand their role, and they might give some information to the students which should have not been given. In my own experience, some of these our standardized patients, especially the old ladies, they feel so have sympathy with the students that they try to really help them because they know the questions and some of the answers. So we have to really train these standardized patients and ask them not to answer only whatever is told to them and not give any additional information. Similarly, training of examiners is very important because we want to standardize, we want to have objectivity in it, valid and reliable questions, and appropriate scoring rubrics and briefing to the students. And and then is the ongoing review and quality assurance. So if we see, it's organizing OSCE is quite meticulous and quite laborious and intensive work. And we have to work really, really very carefully to get the full advantage of the OSCE. The next is it's better to have a OSCE station writing template. Because so that all the questions follow that template. So the examiners and students, everybody is familiar that format. And also this template helps in banking of the questions. I have shared some templates, and I'll show you here as well. So there is a title page, and there is instruction for standardized patients. There is instructions for the student. There are instructions for the examiner, and there are marking schemes. So these are all form of a template. Let me show you that one. For example, this is the one which I have already shared with you as well. So the writing template, So, and we will be using this template in our hands-on activity, where is the 7 steps. First is the station title, and this title helps to um, uh, let's say whether it's a procedure, it's a physical examination, or it's a communication skill. This title would help us to bank the questions accordingly. Then is what is the focus, and then we have to write a summary at the scenario, and then the mark sheet and the guidance for the examiner and the instruction for the students, and what is the equipment required for that particular station. So this becomes a very useful document that each OSCE station is constructed based on this template, and so it helps in that. The second is the marking scheme, which I have also shared with you. Right here is the 3 columns: the satisfactory performance and less than satisfactory performance and unsatisfactory performance. It's better to use 3 columns rather than 2 columns, because if we use 2 columns, either it's satisfactory or unsatisfactory. So either student get full mark or get 0 mark, but we know that many students would perform a procedure but may not be really satisfactory. To have these 3 columns would be useful. All right, so in this way, these templates would really be helpful. So, and then is the next is the now the question was about the duration of OSCE stations. Now, I think Dr. Imtiaz asked that question. So for practical purposes, decision around test length generally need to balance reliability, feasibility, and resources. This means that we have to, first thing is to make it reliable, and then make it reliable within the available resources, and as long as it's feasible. So generally recommended that 14 to 18 stations with 5 to 10 minute duration, let's say a total duration of 2.5 hours or between 2 and 3 hours, can provide adequate reliability. So means that about, let's say, between 14 and 18 stations, any number less than 14 would compromise the reliability, and any number more than 18 would not actually really add to the reliability. Means that if we say that we want to have 25 stations, that would, of course, would put pressure on the resources, but it would not really improve the reliability. So this is a guideline that we have, let's say, about 15, 16 stations, and the total duration about 2.5 hours of this, that would give us a good reliability. Now the next is the role of examiner on an OSCE station. Examiner is not a fly on the wall. I write this because I have heard many speakers saying that examiner is just sitting there, and it has only a role to just do the checklist and nothing else. But that's not true. Examiner has to play a very important role. For example, time management. Now, if there is a counseling station and you have 10 points in your counseling station, and students really don't know how many points you have. and the student might spend the whole time on 1 or 2 points and may lose the marks. So examiner has to actually timekeeping, and if student has mentioned one, you ask them, okay, move to the next, otherwise student might lose the marks. The second is, this is, I think, very important, making sure that candidate understands the task. In my own experience, I have seen that students are really, really nervous. They are in a hurry. They are running from one station to another. And when they come and read the question or the scenario and their task, many of them do it so hurriedly that they do not understand what they actually are supposed to do. So I always ask them that, have you read it, and do you know what is your task? And so that student is very, very clear before doing whatever they are supposed to do. Many a times, I usually give this example. The OSCE says that examine the precardium. And when I ask the students, what do you think is your task? And they would say, my task is examination of CVS. And they would start with the examination of CVS and waste time there. So I think it's always very useful to make sure that student has understood the task, what they are supposed to do. Similarly, another example, we wanted the students to do for example, motor system examination, and students think that they have to do the whole CNS examination. So I think it's important that we make sure that the student understands the task. Any clarification if student need, the examiner would be able to provide that. And any queries, the examiner should be able to answer the students. Now, coming to the type of OSCE stations and the number of examiner, which Dr. Imtiaz was asking, we will be talking about those things here. One is the observed station. And in observed station, our examiner is present throughout the duration of the testing. And the example like communication skills, procedural skills, clinical examination. Benefit is direct observation, allows assessment of the higher level of learning domains. And if it is, let's say, formative assessment, we can give the immediate feedback. So one is direct observation, and second is immediate feedback if it is a formative assessment. The limitation is that it's resource intensive with one examiner needed per station. And Dr. Imtiaz was asking whether we should have 2 examiners or 1 examiner is enough. Having 2 examiners would make it really, really very difficult and resource intensive. So, but if we have a good checklist and very well vetted and appropriate checklist, then I think adding another other examiner would not be beneficial. It would I think the use of resources would be disproportionate to the advantage we would get. So I think rather than asking the 2 examiners, we should be more careful about the checklist and the objectivity to achieve the same goal. Unobserved stations is where no examiner is present throughout the testing period, and answers may be submitted on paper either after each station or following completion of examination. Examples like videos, for example, running a video and then asking questions on that video. So that means that examiner is not there and the video is run, and then here I can give you example. For example, we use a video of a patient with epilepsy. it's a generalized tonic-clonic fit. And then students are asked to describe what they have seen and then interpret. And in this case, the examiner may not be there. Benefit is that examiners are not required, but the limitation is there is no direct observation of the performance. And if student has any problem, there is nobody to guide them there. We should remember this, that OSCE station may not be necessary in some of these stations. The OSCE station may not be necessary, and alternative assessment tool may be as effective as assessing the cognitive skills in the question. So we have to be really careful in deciding about these stations. The next is the technology enhanced station. Is here it's where the high fidelity mannequins are used. These are technological advances. Like I was saying, using the effects of drugs are example like CPR, our decision-making skills, our management of arrhythmia, etc. So these are high-fidelity mannequins which can address this, and these are complex situations which would be good if we are able to do that. However, having these benefits has some issues as well, because the personnel must be trained in the use of this equipment, and equipment failure is a possibility. It's really expensive equipment, and maintenance cost is also high. The another type of station is the linked station, which can be a combination of observed and unobserved. For example, two consecutive stations are based upon the same clinical scenario or information, and these may be a combination of observed and observed. Example: the observed station is observed examination of respiratory system in the first of the two stations, and observed documentation of finding and management plan in the second station. Means that on first station, there is a patient, there is an examiner, and students examine that patient. And when they go to the second station, then they are supposed to answer related to that station. So this is a linked station, and that makes the basis what we call is integrated OSCE. The concept of integrated OSCE is based on these linked stations. The benefit is that a greater number of skills can be assessed per scenario, and efficient use of examiner resources. Limitation is that we have to plan it very carefully. We cannot start from the second station, and we cannot end at the first station. So proper planning would be required for link stations. Another thing is we use the rest stations, and there are a number of purposes. One is to increase the number of stations to accommodate the number of students. For example, if we have 18 stations, but number of students is 20, so we can create 2 rest stations to accommodate all the 20 students at the same time. Excuse me. That is one purpose. The other purpose is to provide rest to the students if it's a quite long examination. So at intervals, students get a rest station. Or at some stations are really more aggressive and time consuming. So in that case, we can give a rest station before the active station and rest station after the active station. That helps to maintain the flow and the time management. Of course, the number of stations would vary according to the requirement. This would be the example that for here, if we feel that this station would really time consuming and intensive, so we can have a rest station before and after that. So even if a student takes 1 minute extra here, still the student, because it's a rest station, so they would not be losing. And similarly, the here. So in this way, we can accommodate some stations which are more intensive and aggressive, and if little bit time is up and down, that can be managed by using these rest stations. All right, and then is the face-to-face conduct of OSCE. I'm sure you are familiar with that students move from one station to another. For this station may be a procedure. Here is a history taking, physical examination, counseling, or video with scenario with different, right. Now, the concluding remarks. First, the clinical practice is a multidimensional, highly complex entity, and designing a performance assessment which robustly tests all domains of practice is therefore very difficult. In other words, no single method is perfect. So we need to have a combination of assessment methods to have a holistic approach. OSCE is one of the components and not the only component of the assessment. And OSCE cannot replace the benefits of long case and short case using real patient, especially in resource constrained situations. If that is possible, I mean, we have seen the limitations of long case and short case, but if we can make them more objective, for example, we use a marking scheme for a well-designed marking scheme for our long case, short case, and we include the end of posting long cases in that. So that can help to cover some of the deficiencies. By using multiple examiner rubrics and marking scheme, the long and short case can be made objective to a great extent. The OSCE station should comprise of procedures which cannot be tested in any other format of examination, for example, insertion of nasogastric tube, videos of episodes which are unlikely to be seen during other format, for example, whooping cough. So there's a video and there's a simulated patient, and we can construct an OSCE station on that. Audios with simulated patient, for example, Strider and the other sounds. Station for focused history, stations for counseling, breaking bad news, although that would be mainly at the postgraduate level rather than undergraduate level. Taking consent from the patient and, for example, a prescription writing. So the other is what should be the pass criteria. I think we must keep the use the OSCE to assess the critical areas, and if we are using the critical areas, the student must pass all the stations. Imagine if we have 50% pass marks and we ask the student to pass half of the stations, so that would compromise the standard to a great extent. With that, I thank you for your attention, and I would be happy to answer if you have any questions before we go on to our hands-on activity. Yes, anybody has any questions or comments?
Sir, I have got a small question regarding the number of students.
Right.
Usually at a place where we are, I mean, the administration is planning to increase the number of students.
Right.
And I'm a bit worried because we've roughly like 28 students last time. We managed to do all the minimum number of stations, that is 12 stations in one day, from
Right.
morning to afternoon.
Right.
Increasing the number of students make me a bit afraid about we need to start at 7 o'clock and maybe ending at 6 o'clock in the afternoon. So maybe
Yeah,
a bit.
unfortunately, that's what's happening in our institution as well. But I think the solution is that if we can divide the stations on 2 days. Let's say if you have, let's say 20 stations, you do 10 station on day 1 and 10 station on day 2, but all the students are appearing on both days. So in that way, you can reduce the burden, and at the same time, you would not be compromising on examinations. So let's say, for example, if we have medicine, surgery, pediatrics, and ONG, these 4 disciplines, we can do medicine and surgery on one day and peds and ONG on other day. In this way, the staff and the student would get some rest as compared to the intense situation which you were just mentioning. That's one solution. Yes,
Thank you.
yeah, okay, Dr. Manoj, please.
Sir, comment only. Am I audible?
Yes, yes.
So what I do is here is I do like we get in India sometimes we have 100 batch students, so we have the total practical examination is divided into 5 days. So
Right.
every day we are getting 20, maximum 25. So what we do is we do it half of the students for OSCE and half of the then for there are four or five components in practical examination we are assessing. Like I'm a professor in community medicine, so I test epidemiology and statistics. I do OSCE. Then I have a case to discuss. Then I have a project to discuss. And fifth is the grand viva. So in that perspective, I divide 2 to 3 hours for OSCE, and then 2 to 3 hours rest of the things can be taken care. So that is another way.
But this is only one discipline, right?
Yes, yes, yes.
Yeah,
I'm just talking
yeah.
about
That's exactly what I was asking, because if we do one discipline on one day, like you said very rightly, then we can actually handle that. In fact, in our institution, we have around 150 students. So to doing OSCE with 150 students on one day is really becomes a huge challenge. But I think you are absolutely right. If we can divide them based on the disciplines, we can manage that relatively easily.
yes, sir. Because sir, we think that CBME is just newly introduced in India in 2019. I
Right.
think what you all are talking is about integrated assessment,
Right.
where multiple subjects can be taken. I think India is still not that in that situation right now.
Right. Okay. Yes. Thank you, Dr. Aisha Iqbal, please.
जी, अस्सलाम वालेकुम sir. Dr. Aisha Iqbal from Pakistan.
Right.
Sir, you just mentioned about designing integrated OSCEs,
Right.
and you gave us the two approach that could be unidisciplinary or multidisciplinary, right?
Right.
So we are already conducting unidisciplinary kind of OSCE. You can say that we design linked stations that are integrated. You start with the history, taking physical examination, coming to the management and related questions.
Right.
So how will we approach towards multidisciplinary integration, especially considering the designing, the number of examinee per stations, and the number of examiners and number of students that can be managed per day?
Right. Okay, I think it would follow the same pattern which you are using for unidisciplinary, but the stations would have different aspects. For example, you start with a pregnant lady who is having, let's say, gestational diabetes. So that's the history station for that. Maybe another station about the delivery, etc. The third or fourth station is that the infant of diabetic mother, right? So now when we are dealing with infant of diabetic mother, we are doing pediatrics. You started with ONG, Now you have included pediatrics, and maybe later on you can say that the some psychological or psychiatric problems about the preparium are that, and you can have a station on that. So basically, you are using the same stations which you are using in unidisciplinary, but now you are integrating. For example, one station can be on prevention, for example, or counseling of that. So in this way, we can make it multidisciplinary. I
Okay,
hope I
thank you, sir.
answered
Yes.
your question. Yeah.
Sir, but how many, like, the thing which comes to my mind, like regarding multidisciplinary integration, that how many, like, stations we can design per day, or how many,
Yeah,
do you think that it
about
will
let's say
cover?
if if you are doing 4 major disciplines or 5 major disciplines, a total of 20 stations, around 20 stations would be enough.
Okay, thank you. And do you think that it will be it should be covered, like the one batch should rotate on a single day, or this can be repeated, or this
Yeah, I
can
mean,
be carried down to the next day?
it depends on your number of students. Uh, if the number of students is huge, then you can do uh, 1 or 2 over 1 or 2 days. But because each integrated OSCE would be assessing a specific area which would not be repeated again, so that should be possible.
Okay, thank you, sir. Thank
Thank
you.
Right. Any other questions? Okay, if no more question, I think can we have let's say a short break? Let's say it is 3:49 in Malaysia now. Maybe just can we meet at 4 o'clock again? Just have a short break. You want to have a cup of coffee or tea? I also think I need a cup of coffee. And is that okay? Please
Yes, sir.
don't,
Yes,
please
sir.
don't
Yes,
log
sir.
off.
Yes, sir.
Keep logged in. Just have a 10-minute break. And yeah, it's exactly 4 o'clock. That means 4 o'clock in Malaysia would be 1 o'clock would be 1 in Pakistan, right? No. Yeah. So just yeah, about 10 minutes break, and then we will have our hands-on activity. Thank you very much.
Thank you, sir.
Yeah,
Sir, there are two questions.
Dr. Pramod has raised hand. Dr. Pramod, yes.
Sir, I had posted the question in the chat box.
Oh, sorry, I didn't look at that. I thought I looked in this interval, but you can, yeah, please mention that.
Yes, sir. Sir, do colleges use a special hall dedicated to OSCE, sir? Do we need a special infrastructure? Because and I saw that the photograph of that infrastructure having cubicles for each stations and all those things. Such in kind of infrastructure dedicated to OSCE is required.
Yeah, definitely we need infrastructure, whether it's dedicated or not. Now, I have experienced that we have arranged in a very big hall where we use the screens and so to separate the stations. And I have also, for example, my present institution, they have rooms as well. We use the PBL rooms. They
Okay.
and that, and we also use the clinical skill lab. But definitely, we need to have an infrastructure. May not be dedicated. We can use the other resources, but that's one requirement. Yeah.
Okay, sir. Thank you, sir. Thank you.
Right. Okay. Assalamu alaikum and good afternoon. Welcome back. Is everybody around?
Ji, Assalamu alaikum, sir.
Right. I hope everybody is around. Now I have created the breakout rooms. I'll open it and everybody please join your breakout room. That's number one. Number two, each group should choose a representative who would be presenting your document on behalf of the group. Third, create a scenario, a small scenario, and then use all the 7 steps of the template. I hope everybody has that template because I had shared it in the group. If you do not have, I can share it again. And so you have to create a scenario and following that, the requirement of that template and make a marking scheme. I think we will fix around 20 minutes for this. And after that, we will, each group would present their OSCE and we will discuss about that.
Sir, I haven't received the template. Can you please share? Anshu.
Okay, I'll do that. In a minute, Anshu, Dr. Anshu, you are in room 3. I'll share with you on your WhatsApp.
Thank you.
Yeah. Okay, any other comment or question? Okay, I'm opening the rooms. Please join your rooms.
Excuse me, sir. Sir, the template file that you shared is in PDF, so if they have to
Sorry?
edit in that file, then they need the Word file.
Sorry,
Or
is it Dr. Adil?
I'm asking if the template file that you've shared is in PDF format. So if they have to write within that file, then they would be needing the Word file.
Okay,
But
I purposely actually followed the PDF because I wanted you to write separately.
Okay, that's okay, sir.
Yeah, that was purposely done.
Okay, sir.
Yeah. Dr. Adil has not joined. Dr. Adil, any issues? Dr. Adil, you can you can join room 2, please. Dr. Anshu,
Yes, sir.
have you received?
Yes, sir. I've got it on my WhatsApp just now.
Right.
Thank you.
Okay. Thank you. Thanks.
Okay, actually, I have done two kind of OSCE questions. One is whatever you say, interpretative or pen and paper. And another one is the active stations based on
Good afternoon. Dr. Pramod, you haven't joined, you have not joined a group. Is there any problem? Oh, okay, okay. Oh, right, okay. Yeah. Okay, thank you. I thought you have not joined. Yeah, okay, thank you. Thanks. Thank you.
Sir, Assalamu alaikum. I'm Dr. Alia. Can I
Right.
join the room 3? My phone has some
Okay.
problem.
I'll assign you that room. Okay, yes, please go ahead.
Thank you, sir.
Thanks.
Okay.
Okay, no problem.
Let's put it, keep it
Then-
10, and then we'll see if
And see if
later we
it's-
see. Let's see what. Okay. Then we have defined the focus of the station, in which we will tick one box. So it's a history taking, physical examination, professional encounter, procedure, or practical activity, which is OSPE.
Assalamualaikum.
Walaikum salam.
Is everything okay?
Yes, we were unable to write in the PDF, so we are just writing
No,
back.
I purposely did that because I wanted you to write separately.
Okay,
Correct.
that's what we are doing, sir.
Okay.
You are successful.
Thank you. Thank you.
Thank you, sir.
Good afternoon.
Good afternoon, sir.
Yeah, is your group okay?
Yeah, yes, sir.
Okay. Okay. Best of luck. Best of luck.
Thank you, sir.
Assalamu alaikum.
Walaikum
Yes.
salam, sir.
Yeah, Dr. Anshu, I read your message, but I purposely sent the PDF because I wanted you to write on a separate sheet.
Okay, sir.
You can
Okay,
use
sir.
the
Actually,
headings.
we are having difficulty in copying the question, so that's okay.
No need to copy the question, just say the number.
Okay, okay. Thank
Okay.
you.
Yeah.
Mhm.
Four. So the
I think that is regarding the marking as well, right?
marking,
So it could,
the emphasis also, yeah. So
so it's like more of a marking criteria for the examiner. So it could be explains, it could be satisfactory, unsatisfactory, or
yes, those 3 points
no,
will,
no satisfaction. So satisfactory would be full 1 mark, partially satisfactory would be 0.5 mark, and 0 would be for incorrect answer or something like that.
Assalamu alaikum. Good afternoon.
Good afternoon, sir. Yes.
Good afternoon, sir.
Is everything going well?
So far, so good, sir.
So
Okay.
far, so good.
Best of luck.
Thank you,
Thank
sir.
you.
Thank you, sir.
Now we have done with the station, I guess.
And then third thing, what equipment is required is standardized patient.
Yes, thank you.
Less time provided for this workshop, sir. I mean, for this exercise.
Yeah.
Assalamu alaikum. Good afternoon. Welcome back. I hope you had a productive discussion. Now, can we start with room 1? You can use this the representative of room 1. Use the screen.
We actually have nothing much to share. We were like sort of discussing the points.
Okay, that's fine. That's fine. Let's see what you have.
Okay.
Can everybody switch on your camera, please, so that we can see each other and have a lively discussion? Yes, no, I know how Dr. Manoj looks like. Yeah, Dr.
Yes, sir.
Anil.
Thank you.
Okay. So, Dr. Naila, is it?
Yes, sir. So
Yeah, please.
we are group 1 and we selected the topic of upper GI bleed. We gave it a duration of 10 minutes and we were working on the history taking segment
Right.
of that.
Okay.
We were just we were able to write down a scenario, sort of a 50-year-old man who came with bleeding per mouth and is chronic alcoholic and has been in hospital where he received a transfusion. Sort of a short storyline. And then we had we were discussing that there will be a simulated patient. We did not finalize any script for the patient yet. Neither the instructions for the students, but we were just doing the marking in how are we going to divide the marks for this activity.
Right. Okay. Now, before I ask anything, anybody has any comment on that?
I think the time allocated is a bit limited. Sorry. I think the time was a bit short in trying to get both the marking sheet and the scenario.
Yes.
Okay. Right. Now, first is your title is history taking, right?
Yeah.
It should, because this title helps in banking the question. So that would be the history taking. Okay. Now, so you want a simulated patient and who is having bleeding per mouth. So what would be your first, if you have done this scenario, what would be your next step? Your group, after doing this scenario, what would you do next?
Next means in the...
No, let's say you are developing this question. You have done this scenario. What is the next step, immediate step you would like to do?
To sort of pilot it?
Oh, right. I mean, you have to first write the questions which you think students should ask.
Okay.
Right? So you have this scenario, then is sort of your model answer.
Okay. So here we should first do the model answer.
Model answer. So
okay.
Once you have written your model answer, then the marking scheme would be easy to do, right?
Okay. Okay.
Yeah.
Sir.
So you have history taking, you have a simulated patient who, and this is the bleeding per mouth, and because this is a focused history, right?
Yeah.
Yeah, it's a, so we have to emphasize on that, because within the limited time we can have only focused history. We cannot have everything. So basically student should be the question should be around the differential diagnosis of bleeding per mouth, right? The question should be very, very specific. So once you have thought a few differential diagnoses, so questions should be very well directed, very focused. So once you have the questions, then you can have the marking scheme. Right. Now so here your marking scheme you want to do in 2 columns or 3 columns? Anybody from this group can answer?
Yeah.
Should be 3 columns.
Yeah, should be 3 columns.
Because it's not a procedure. We are simply
sorry, can every others mute you, because there's a background noise. Please mute. Yeah, so okay, so So you would have 2 columns or 3 columns.
3 columns.
You think the questions, yeah, I think there's somebody has not muted.
As a host, you can say mute, please.
Can you please mute? Others can mute, please.
Oh, sir. So in the checklist that you have provided, you have 4 columns actually.
No. Here I'm asking that when you are taking history, is it Dr. Adil? Dr. Adil, can you mute yourself, please? Dr. Adil, can you mute yourself, please? Dr. Adil, can you mute yourself, please? Dr. Adil, I think Dr. Adil is using handphone and he's moving around. So, okay. Now, Dr. Adil, please mute yourself. Okay. So question is that whether you would like to have 2 columns or 3 columns. If you are taking history, so student would either ask the questions or they wouldn't ask the question. Would it be that they would be asking some not appropriate questions?
Yeah, so we should keep a sort of
I
like a 0.5
I think you need to think about it, right? So basically, if I summarize, so this is a station which is on history taking, and it is a focused history taking. It is from a simulated patient who presents with bleeding per mouth, and after that you have to first write the questions. Now here the issue would be how many questions. Let's say, is there any minimum number of questions which you want to ask the student?
Yeah, there are questions relevant to the present history taking and the past medical illness and so on.
That's what I'm saying, that we have to focus. We have to focus. We have to give the direction to the student. That Dr. Mateen Shahid, please mute yourself. Please mute, Dr. Mateen Shahid, can you mute yourself, please? Dr. Mateen Shahid, please mute yourself. Okay, now we have to, because student doesn't know how many questions you want him to ask. And if you have 10 questions, you have 1 mark for each question, and student ask only 5 questions. Then student would be losing the marks.
Okay.
Right? Now, what's the solution? Solution is that you have some important questions. Means that you must identify that these are 5 or 6 questions which are crucial, which student must ask.
Okay.
Right? So in that way, although student doesn't know that how many questions he needs to ask, but because you have identified the critical questions, as long as student answer those critical questions, he or she would get the full marks.
So that will be by giving more marks to those questions?
No. It means that you have critical questions and that student must ask. So if student are asking other questions, it's okay, but you would mark only on critical questions.
Okay.
So this means if student is asking questions which are not really relevant, you can ask the student to move on to next question, to next question, to next question, so that they do not waste time on questions which are not really giving any marks. So,
And we will say this in our instructions to the examiner.
right, absolutely right, right? So these are critical questions, and there would be marks for each critical question. Student may ask the other questions which are not critical or less relevant. It's okay, but we would not mark. But if student is spending too much time on these other questions, you ask him to move on to next question, move on to next question.
Thank you.
Right? Any comments from the floor?
Yes, sir. I have a comment, sir.
Yeah.
Sir, before coming to your last comment regarding the some crucial questions, I want to say that this is in the history taking. From these two lines, I am totally understanding that maybe it's a case of chronic liver disease or cirrhosis of liver. But you see, so it should be focused, and the title and the question scenario should be moved, because bleeding per mouth is included other than the many other causes also.
Right.
So if it is focused at vomiting with vomit or vomit mixed with blood, it is more focused. The student will be, I mean, very calm to do. And regarding
absolutely right, absolutely right. Very good idea. Absolutely right. Because when we want the focused history, we have to remove the distractors.
Okay, then you see the 10 marks, 10 minutes. Okay, fine. It could be 10 minutes, it could be 10 marks. You know, in 10 marks, some points are also going out of the history taking. Suppose professionalism, attitude, or professional, what you say, and you know, introduction, bonding with the patient, taking permission, consent, all some marks is going. So I believe maybe 7 to 6 marks will be in the history taking. But the main thing is calibrating the crucial questions. It's really very crucial for the examiners, right? So better we will have a list of questions on the list of the questions on the history taking in different segments, like presenting complete drug history, previous surgical history, and family history, contract history. This one thing. Maybe there will be maybe 10 to 15 questions will be there. So if we count 7 marks from that one, any one question from that one student is asking, I will mark that one, instead of calibrating the crucial questions.
Okay, Prof. Kabir, let me come back to this. I think your first comment is excellent. Rather than saying bleeding per mouth, maybe you say hematemesis, right? So then now we are focusing, the student has more focus on that. Now, the way the student is asking the questions would tell us what is the differential diagnosis the student is thinking of. So you can further limit it to say, okay, ask the history of presenting complaint. If you have time limitations, you can limit the question in terms of, let's say, if you have, because the focused history means that you would not be asking the other questions. It would be relevant to that. And during your vetting, you would identify, let's say, what are the most likely differential diagnoses, and for each differential diagnosis, what are 1 or 2 most important questions. Right? Now, limit here is that student doesn't know how many questions you are expecting. But your criteria is that there are some critical questions. There are some very important questions which are directly related to, let's say, you say the hematemesis, you would ask any liver disease, for example. Or let's say the ulcer history related to which might indicate ulcer. So I think during the vetting, we have to identify the minimum number of questions which a student must ask. The third point about the total marks, it's okay. Total marks may be 30, adding other marks, because at the end of the day, they would take the percentage. So let's say each station has, for example, 10 marks. So it doesn't matter, you can mark out of 50, but it would be converted to out of 10. So because if we limit it to 10 marks, that is artificial limitations on the question. So we do not limit that. We give the examiners full independence to write a complete, maybe of 50 mark, but we will convert to 10 marks at the end. Important point in this, I think important lesson for in this is that one is the scenario. When we are asking the focused history, the scenario has to be focused as well. We cannot ask, so like you said, hematemesis, yes, now it's focused. We are talking about hematemesis. We are not talking about bleeding from the gum or epistaxis or etc. And number two is that we identify the critical areas, because OSCE is meant to assess the critical areas. So, and that's why I said my opinion is that student must pass each station because they are critical. So in that way, I think we can handle this. Any other comments?
Thank you, sir.
Sir, I would like to say something about this particular case, if I can.
Sure.
One thing is that the task for the student should be very specific and clear. That the chief complaint has been given to them that the patient is coming with hematemesis. So they need to elicit history of present illness to arrive at a provisional diagnosis.
Right.
And then would in turn also specify the level of the performance and tell us how to mark it as well.
Right.
Because if it would be the way it is going, it would be more appropriate for a long case if you are interested in the whole of the history. Since we are segmenting it, then the segment should be very clear.
Absolutely right. That's why I was saying that we can limit it to history of presenting complaint, because you have to do it in that the specific time, within that time. And the other way, as you said, is to make the scenario in such a way that student thinks only of those possibilities. A good student would think of those possibilities. They wouldn't go into the unrelated areas. So the skill of formulating the scenario would come into the play. Basically, as I said, the hematemesis, I would say that the few differential diagnoses, important differential diagnoses, which are very relevant to that area. And then maybe let's say 2 questions related, which are very critical for each differential diagnosis. That would be the minimum requirement. Right, can we move on to room 2, please? Room 2.
Yes, sir. Just a minute, sir.
Yes, please. Is Dr. Pramod going to present?
Yes, sir.
Okay, please.
Sir, I had made I am a dental faculty in oral pathology, sir.
Okay.
I just made a scenario where there are 4 PGs in our department, and they go through this OSCE.
Right.
And with a standardized patient having a pre-malignant lesion in the buccal mucosa.
Okay.
So I just made so for this standardized patient some instruction that the patient should allow history taking examination and to cooperate for the smear preparation. and regarding that case, clinical feature, that burning sensation, unable to eat spicy food, and history of tobacco chewing since 10 years, all these things I had written for an information for the examiner itself. And I had I could make 4 stations. One is for history taking, one is for physical examination, the other one is for procedure, and the other one is for counseling, and other one is for counseling and the prevention of the habit. So this one in the history taking, the same thing as it was given in the template, sir. Greeting for that, the marks.
Okay.
Yes, sir.
Dr. Pramod, may I comment here?
Yes,
So
sir.
first is that actually you have made 5 stations.
Yes, sir.
At one go, you have made 5 stations.
Yes, sir.
So let's say if we talk about, let's say you want to, and this means that if you arrange these 5 stations in a row, that would be your integrated OSCE.
Yes, sir.
Because you are talking about the same patient, but then you have to work on each station separately.
Yes, sir. Yes,
For example, technique station would be separate, history taking would be separate. Now, the advantage would be, what happens, for example, in long case, when we are marking, the examiners usually become biased. For example, student has taken a poor history, but then student go on to do a physical examination, and the physical examination is excellent. But because the examiner is biased, that with the negative impression that student was not good in history taking, they would give less marks in physical examination as well.
Yes, sir.
The good thing about this integrated OSCE is that each station is an independent station, and the examiner sitting there does not know about the student performance in the previous station.
Okay, sir. Okay.
So the examiner bias would not be there.
Okay, sir.
Right? So each station has to be an independent with complete set. In that way, and complete set of marking, so that each station is assessed and marked separately without knowing what happened in the previous station.
Okay, sir.
Because obviously students' performance is not same throughout. Sometimes they are good in history taking, maybe poor in physical examination, maybe good in taking the smear, right? So and number 2 is that in this kind of situation, you will have to guide the student to some extent. For example, when it comes to the buccal smear, then you have to say in the scenario that the patient is suspected to have this whatever condition.
Okay, sir.
You have to tell that student the patient is suspected to have this. Now you want to take a buccal smear. So how would you approach that? And obviously that would be the consent, and then would be the technique, and then would be the how to dispose of the specimen, etc.
Okay, sir.
Sir, a question I'd like to ask here is, will any patient allow the scrape to be taken even if it's 4 students? Is it ethical to allow a scrape to be taken? It's going to be difficult.
Here is what Dr. Pramod is saying, that they have 4 students.
4 PG
right?
students.
Yeah, only 4 students. So if you can brief your simulated patient that the students are going to do this procedure, because number is only small, so the patient might agree, the person might agree. If it's a large number of students, of course, then that would not be possible. But here only 4 students, so I think that should be feasible. Okay, any other comments, please?
Sir, you expect for history taking there should be one standardized patient there, and for technique the other standardized patient.
That's right. That's right. That's right. Because each station has to be independent.
Yes, sir. Yes, sir. Thank you, sir.
Okay, Dr. Farzana has a question.
Yes, can you hear me, sir?
Yeah, please.
My question was that this, because I was in room 2, but I'm in clinic, so I was not able to communicate with but I have one question that if you have make this integrated OSCE, like for example, 4 station,
Right.
in half an hour, if you are putting a one diagnosis, if the initial and history taking stage, the student get a wrong diagnosis or provisional diagnosis wrong, then all her stations are going to be defected based on that history and provisional diagnosis.
Right. Yeah, you are absolutely right, Dr. Farzana. That's why I said that in each station you would have to guide the student.
Yes, this is very important. Otherwise, because in half an hour you cannot check
like I was saying, the station on buccal smear, you must. The scenario should be that the patient is suspected to have this disease, and you need to take buccal smear. The integrated OSCE is like multiple part of MEQ, where each station must guide the student accordingly. You are right. If history taking student has taken a wrong history, the next is physical examination. So there should be some indication to the student that what they need to examine. Because we cannot penalize the student multiple times for the same mistake.
Yes, thank you.
Right.
So like a linked student, linked OSCE station, right, sir?
Right. Yeah, because I mean, if student has made mistake on one station, he should not be punished on the subsequent stations for that mistake. So we have to sort of bring back the student to the right track.
Correct, sir.
All right.
Yes.
Okay. Any other questions?
Sir, I just wanted to comment about one thing.
Right.
That in case of integrated OSCEs, if we are having all the station as integrated, the element of case specificity and the content validity would be there, because the sampling would be then reduced of all the skills that are required in a particular assessment.
Yeah, Dr. Aisha, the literature says that if you have, let's say, 4 or 5 integrated OSCEs, and your total number of station is around 20, that is good enough. So let's say you have one, if you are having multidisciplinary, that would be even better. In otherwise, you are having one long case in ONG, one in pediatrics, one in medicine, one in surgery, and you are dividing them into multiple stations. So basically, in a way, you are going back to your old tradition of long case, but this time is very much structured and the objective. So it's basically a better way of doing the long case.
Yes, sir. And sir, one more thing about this particular station that the participant is presenting.
Yeah.
These are postgraduate students. So wouldn't it be better to have DOPS instead of OSCE? Because they would be doing on actual patients, and if it can be taken as DOPS, that would be one thing. If it needs to be done in an OSCE, then they can have the history taking from the SP, and the phantom head can be used for the procedure.
Yeah, they basically, that's why I was saying that each station has to be a complete and independent station. Although they are linked, but each station has a different focus. So Now the OSCEs are being used in postgraduate as well. So even the College of Physician and Surgeon is using TOEIC, which is of course OSCE.
Sir, actually,
yeah.
Sir, can I make a comment, sir? Actually,
Yeah.
sir, I mean, the institute to institute and program to program is varied, because the institute who doesn't want to go for real patient long case and short case, so it must be replaced in the OSCE with the integrated, the scenario we have in front of us in the screen.
Yeah, that would be better choice. Yeah.
But in some institute that for the professional examination final, the long case and short case is there,
right,
for medicine surgery. So
right,
in their OSCE exam, final exam, there is no station for the medicine surgery. Whereas for the emergency medicine, anesthesia medicine, I mean, OSCE is one of the component with the other assessment as well as MCQ, short Q. So, I mean, it depends, it varies.
Yeah, Prof. Kabir, let's say if you have a medicine and surgery long case, but you can still have OSCE based on the procedures, for example.
Right, sir.
Yeah,
that we cannot perform in the hospital to help our students to learn.
Yeah,
yes.
Yeah. So you can still have counseling station, you can have procedures, still you can have that. Okay, let's move on to the next, which is room 3. Okay.
Are you able to see this, sir?
Yeah, yes, please.
Okay. First of all, say actually we couldn't finish due to lack of timing. We followed the things that the station, it's observed station, active station, duration put 5 minutes.
Right.
The physical examination. The focus of the station was a physical examination or clinical examination, what we say. And the summary of the case was the physical examination of the trigeminal cranial nerve, 5th cranial nerve in a real patient.
Right.
And the patient have left-sided trigeminal nerve palsy, having the following findings: the loss of soft touch and pain in the ophthalmic and maxillary division of the CN5, but the medullary division was intact, and loss of tone of the muscles of the first brachial arch.
Right.
The corneal reflex not performed.
All right.
And the scenario of the patient actually, which was for the students' guideline, I mean students' instruction. A 65-year-old diabetic, hypertensive, and dyslipidemic patient presented with difficulty while eating and numbness over the left side of the face. You are requested to perform the physical examination of the 5th cranial nerve.
All right.
And coming to the design of the marksheet, so these are the dictation for the rubric and the dictation for the examiner, the gather equipment, hand sanitization, introduction, and content the patient's name and date of the birth, proper explanation about the examination using patient-friendly language, consent gaining, position of the patient, then sensory examination of the cranial nerves, trigeminal nerves, then the motor examination. Finally, the overall examination skill and findings. I mean, it's a real patient, so technique of the examination as well as their interpretation, findings is okay or not, based on that one, and professionalism.
All right. Okay, now, Prof. Kabir, first thing is your title should be the physical examination.
Not observation, right?
Yeah, because you are actually, title here means what is the main thing you want to do. You are doing physical examination. All right, so that's number 1. Number 2, the real patient. You think you can use real patient in OSCE?
Sir, actually, in my last institute, in the OSCE, all was real patient.
How many students?
2 days, every day was 30 students.
Then
We could perform because we involve.
Then you must have multiple patients.
Yes.
Yeah. So actually, that may not be possible everywhere, especially when we have 100, 130. Right. So if, for example, you do not have a real patient, but you want to have this examination done, how would you approach?
Okay, we have to we have to teach the patient. We have to it's possible that teaching the patient, acting, I'll ask the patient to act.
Right.
And I'll do this. Simulated patient. We can do it in a
Right.
simulated patient.
Yeah. So here now there are some things which patient can mimic, and there are something which patient cannot mimic. For example, if it's a scenario saying abdominal pain and appendicitis, the patient might mimic tenderness when student press that area. But there would be areas where patient cannot mimic. The other solution is that for that, we can give the finding to the student. We examine the technique, and then let's say, and then we, for example, if a student is doing the knee jerk. So we examine the technique, but for interpretation, we can say, okay, it is brisk or it's not. So we can work on in that the things which a simulated patient can mimic, we can use that. But where the things cannot be done, so examiner can provide the findings. Like I gave the example that we asked the students to auscultate, but we used an audio to tell the student that this is the murmur which was heard in this area. So in that way, we can combine different things to improve on that. Any comments from any other participants?
Sir, when we are taking such cases, and we want them to interpret some certain science, for example, when we have make the patient students do the extraocular movements on an SP,
Right.
but the third nerve palsy cannot be simulated. So we
Right.
show them a video of third nerve palsy and ask them to write their findings for that.
Right. Now, it is video along with simulated patient or only video?
Sir, both.
Both.
Simulated
Yeah.
patient, they perform the extraocular movements, and the video is the next station.
Yeah, there's a linked station. That's I think very good. That's very good. The using linked station. First, you see the technique. First station. Second station, you provide a video where the findings are there. So that would be excellent approach. Okay.
Prof, just got a small comment. I don't know if this makes sense, right? Sometimes these 5 minutes will be sufficient for examination and discussion about this case.
Right.
And number two is a bit too much focus a bit on the fifth cranial nerve. There may be associated cranial nerve together with the fifth nerve involved.
Yeah, right.
So,
basically, you're absolutely right. When we are vetting the questions, the OSCE, the first question we ask whether it is feasible within, let's say, 5 minutes. That should be the first question we ask, whether this task student can perform. Let's say if every station is 5 minutes, whether student can perform that in 5 minutes or not. If cannot, then they have to cut down the question and make it more focused. So because the time we have to limit our task, which is possible in that limited time. That should be the first concern about any question. Right?
Yes, sir. That's why, sir, nowadays they I mean, the synchronization of the timing is there to keep the synchronization of the timing, that keep the timing all together same. What they do, they don't say the examination of the chest. They give just only focus, auscultate the chest from the back, just only for
Right.
keeping the
Yeah.
5 minutes. Okay.
But if
So that's why the trigeminal only one nerve. One
no,
nerve.
but if you want elaborate, you can have a linked station.
Yeah.
Yeah.
Right.
So you have like Dr. Aisha was saying that you have technique on one station, findings on the next station, a linked station. You can
Sir,
use that.
but it's very, I mean, challenging for the student. I mean, one student, if one link they miss something, the next link they will.
No,
I mean,
it's no, Prof. Kabir, on first station you are looking at the technique.
Okay.
But second station you are playing a video and showing them these are the findings, and then they work on that. So yeah. Okay, can we have the best part now, the final? We kept the best to the last.
Is the screen visible, sir?
Yes, Dr. Manoj. Yeah.
Yes, sir. Good afternoon, everyone. So I'm presenting on my behalf of my team, Group 4. We have chosen a counseling station, sir. Title is counseling.
Okay.
A standardized patient is a mother on how to prepare oral rehydration solution.
I'm glad. I'm a pediatrician, so I'm glad to have that
Yes.
kind of station. Yeah.
So how to prepare oral rehydration solution for our 1-year-old child who's come with diarrhea, 10 marks.
Right.
So students are instructed that they have to explain reconstitution of the ORS and its administration to the mother for this 1-year child.
Right.
So greeting and introduction, consent, 1 mark. And the second step is instruction. So we have divided into 4 phases, sir. Second phase is instruction following the reconstruction of the ORS, which is carrying 3 marks. Washing hands, 6 steps.
Right.
Then second step is asking for a clean vessel and then showing the how to mix the content of the ORS with 1 liter of boiled cooled water. So what I have highlighted with yellow is a must know component.
Right.
And third thing in this is keeping the water covered and the solution can be used within 24 hours only.
Right.
The third component is instructing how to use now, how to administer. So it has got 4 steps. Use a clean spoon for administering 1 mark. Second is use 1 teaspoon every 1 to 2 minutes.
Right.
Third thing is after each stool, give a quarter or half a cup, which is equivalent to 50 to 100 ml of the solution. And fourth thing, if the child vomits, wait for 10 minutes and then again give 1 teaspoon of ORS every 1 to 2 minutes.
Right.
Then the fourth part is closure. The examiner asks the questions on, this is what we just thought, whether he can ask a differential diagnosis or severity of diarrhea. Here we can play a video also, sir, of different severities and ask.
Right.
And when should the mother, if there are any danger signs, if the child does not improve despite of this, when should come to the hospital? That is, these are carrying two marks.
All right.
And since this is all 10 marks collectively, satisfactory performance, if he gets 8 to 10 marks is satisfactory. Less satisfactory if he receives 6 to 7 marks, and not satisfactory 5 and less marks. And the equipment required would be all the contents to show the making of ORS, which is vessel, spoon, or ORS packet and water.
Right. Okay. Dr. Manoj, you want the student to simply explain or prepare the solution?
Prepare, sir, because that would show mother.
That's excellent. Yeah, because that's really you want to show the skill, preparation, and after preparation, giving the instruction. That would be good.
Yes,
Now,
sir.
But how would student know that you have 4 or 5 steps? Student might spend the whole time on preparation.
Yeah.
So this means that you have to prompt the student. Okay, what is the next thing you are going to do? So this means that as an examiner,
Yes,
first
prompt.
you are asking the student to prepare. Then you would, these could be either written question or verbal question. So you ask the student to prepare, and then you ask the student to, okay, instruct the mother about the administration.
Yeah, one thing is, sir, he can verbose, means verbally he can tell what he is doing when he is preparing. So
Right.
the standardized patient is knowing what are the different steps he is, how to prepare.
Absolutely right. But actually, this is good that student, rather than telling how to prepare, is actually preparing.
Showing, yes, sir.
Yeah. So my concern is, if you have 4 or 5 steps, so you have to guide the student from one step to another. Otherwise, they
Yes,
wouldn't know.
yeah.
They wouldn't know. So that's number one.
Yes, sir.
Number two, this rating for faculty, actually, you do it satisfactory or less satisfactory after.
Yeah, at the end, sir. At the end of
Yeah.
cumulative
So,
score, yeah.
no, basically what we do is what we call is the global rating.
Yes, sir.
So we do not ask the examiners to, let's say, add up the marks. They give the marks and they don't add up, and at the end they give the global rating. And then we use
Percentage.
no, overall satisfactory, less satisfactory, or good or bad or excellent. We have that category, and then we use that to find out the standard setting. So this criteria of satisfactory, less satisfactory, it should not be on the paper.
Okay, sir.
Yeah, it should not be on the paper.
Yes,
Yeah,
only.
Dr. Anam has a comment here, which is same as 1 and 0.5 and 0, that mark. So in your case, is actually not only counseling, but it's also some active, so it is demonstration and counseling, basically demonstration.
Yes, sir.
Demonstration of preparing the ORS. I think the last step may not be necessary, the severity.
Okay, sir.
And when you want them to instruct the following for administration, here you have to mention the student that which degree of dehydration you are talking about. Because the giving oral fluid would change if degree of dehydration is different.
Yes, 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 yes.
So that's why in this kind of question, either it is a linked station, our examiner has to play a very active role in directing the students.
Dr. Manoj, there's a question I wanted to ask you. Now, this
Yes,
is a
ma'am.
very nice station. My question was the practical issues with actually keeping that much of water and ORS practical. If there are 20 students, how are you going to change the vessel and everything in demonstration? So it looks very nice on paper, but when I'm thinking of it in terms of 20 students coming around, how are we going to do this?
That's excellent thought.
Yes.
Yes, you have to have vessels, and so you have somebody has to dispose
The
of that
vessel,
water.
vessel spoon will be 1, but ORS 20 packets and bottle
Yeah,
20
no,
liters.
important would be that once one student has to move, then you have to discard that the solution
replace,
somewhere.
yes, sir.
So yeah, I think Dr. Anshu is really thinking forward to.
Yes, but that's how OSCE is expensive, no?
Yeah.
Thank you so much, sir.
Any other comments before we close the session? Actually, we are already 20 minutes over time.
I've got an overall reflection actually. how much time do you need to devise all that? I mean, an average time for an OSCE, because sometimes, you know, I take 1 day, even 2 days to be able to do all that. Of course, not during working hours, but to divine, you know, like to design the OSCE, look at the student if they can do that within 5 to 10 minutes.
Yeah,
What
Dr.
the
Imtiaz,
priority setting?
Dr. Imtiaz,
Yeah.
it's not easy. It's not easy. It is quite intensive. It's laborious. There's a lot of thinking and a lot of vetting. So it's we cannot take OSCE lightly. And then we have to be specific, and the important thing is within that limited time. So it really takes a lot of effort and thinking to come up with a good OSCE. But good thing is that once you have developed this and students have performed and you have done the standard setting, then they go into your question bank and then they can be used later. So it's not just one-time use and wasted. It can be a useful asset for the institution.
So, sir, can't we create a global type of question banking for the OSCE so that everyone can use it?
Yes. Yeah, yeah, let's say Indian Medical Council has a bank of OSCEs if they can do that.
Yes.
Yeah, so that would be good.
Yeah, sir, for
At least-
nursing it is there, sir, already there.
Oh, right. So you can get some questions from the bank and some percentage you can develop yourself.
Absolutely, sir.
All right. Okay, there's a hand signed by iPhone. Sorry, I don't know the name.
Sir, Assalamu alaikum, sir. I'm Dr. Alia from Rahman Medical College, Peshawar. I have to ask one question, that is it okay that the assessor for the specific OSCE should be of the same specialty, or anyone from any other domain can do the OSCE or can be the assessor with the checklist?
Theoretically, other people can do, but best would be the person from the same specialty.
Okay, sir.
Yeah, but although people claim that if the checklist is so perfect, but still would be a medical person. Let's say if it's a pediatric pediatrician may not be available, but maybe a physiologist or an internal medicine or somebody who at least have some knowledge about that.
Okay, sir. Thank you, sir.
Okay.
Prof, a follow-up question on that, on what the previous colleagues have mentioned. Is it that if you ask a content expert and the student being, you know, like an undergraduate student, that makes, you know, a big difference in the assessment quality, because the expectation may be a bit too high at times.
Right. Actually, there are two things. One is that we have to train the examiners. And second, there is a checklist. So examiner cannot go out of the checklist. I understand what you are saying is that if the examiner is a specialist, so their expectations may be very high. Same problem we get when we are, let's say, facilitating problem-based learning sessions. The experts there, they actually cannot control themselves, and they start giving lectures. But a good training to the examiner is really important.
Okay, thank you.
Okay. I think we are coming towards the end of the session. I really thank for everybody. At least I enjoyed the session. Sharing your experiences and discussion. Yes, Dr. Adil, you want to say something?
Assalamu alaikum. Just a small query that all the stations that have been discussed here are mostly interactive stations. So what about non-interactive stations like interpreting a radiograph or CT scan? and then maybe making a differential diagnosis and followed by maybe that can be made a little interactive by a small Viva at the end. So how do you rate that kind of thing?
Dr. Adil, the first question you need to ask is whether you really need an OSCE for that station. For example, if you have a lab report, or if you have an X-ray and you ask the student to interpret the X-ray, do we really need an OSCE for that, or we can test it in other platforms? Usually we say that something which can be tested with pen and paper alone should not be an OSCE.
Okay.
Yeah,
That should not be.
OSCE must have something hands-on. Something hands-on must be there. That's why I mentioned that let's choose the critical areas for OSCE. Something which we cannot do in other areas, like some procedures, our communication, our counseling. So there is something active to be done by the student rather than simply pen and paper, because they can be tested in written examination as well.
Okay, fine.
Right.
So,
yeah.
And what about the instrument, maybe in surgical field? Because in surgery, you cannot, other than examination and few some very limited procedures, you can assess in the
Dr.
OSCE.
Adil, if you want to, let's say, put an instrument, then examiner should be there, and student should not only identify the instrument, but should show how to use that.
Okay. Okay,
Yeah,
fine.
because the activity should be there.
Okay. Something hands-on.
Right. Yeah.
Thank you. Thank you.
Okay, and right.
Sir, I just shared the checklist, what the basic checklist for ANMs use, the ANM course in India, no?
Right. Okay.
So there are some, yeah.
You have shared in the chat box, is it?
Yes, sir.
Okay, wait. Right. Okay, we will keep this WhatsApp group active for next few days, so that if anybody has any question or comment, you can share. Same time, Mr. Ihtisham would be sending you the participation certificates, and until that, we will keep this group, the WhatsApp group, active. So for any question or queries, right? Okay. Once again, I thank you for your excellent participation and making my afternoon and evening really wonderful.
Thank you so much, sir.
Thank you so much,
sir.
Thank you so much, sir.
Good session. Thank you, sir.
Hope to see you in next
Inshallah.
sessions.
Thank you.
Happy New Year, sir.
Oh, Happy New Year. Yes, Happy New Year.
Happy New Year to everybody.
Let's end at
Happy New Year,
that.
Yes, Happy New Year,
that
sir. Yeah,
meeting.
Happy New Year. Yes, to everyone, Happy New Year. Yeah.
Thank you very
Happy
much,
New
sir.
Year. Okay. Bye-bye.
Allah Hafiz.
Allah Hafiz.